Lawrence Muscarella. I received my PhD in engineering from University of Pennsylvania in 1990, and I have become a national safety expert, investigating the causes and prevention of hospital infections that are linked to essentially reusable medical devices such as colonoscopes, flexible endoscopes, heater cooler devices, other types of devices that can become colonized with organisms, infect patients, and for which hospitals need to disinfect between patients to ensure safety.
All right, thank you so much. So, the Davidson County Department of Health spokesperson told us that they were alerted of inappropriate practice on the part of a technician at VUMC that had the potential to transmit bloodborne pathogens. And as we previously know from Vanderbilt, they had told us that patients during endoscopy procedures over a 6-month period could have been potentially exposed to HIV, hepatitis B or C. So, in your expertise, what could be defined as an inappropriate practice on the part of a technician when it comes to colonoscopies?
So it's kind of a global term or description that they're giving us because there are many things that could be inappropriate practices that could increase the risk of patients being exposed to bloodborne pathogens. In this context, and of course, these are hypotheticals because we don't know enough, we haven't been provided enough, so it's hard to comment specifically. But I'm thinking of a few couple things that could be in play here. Of course, may not be, but could be. And one would be, for example, one of the internal channels of a gastrointestinal endoscope. And when we talk about GI endoscopes, we're talking about generally colonoscopes that are used in the lower GI tract and gastroscopes that would be used in the upper GI tract. For example, to examine the mucosa of the esophagus, the colonoscopes are, of course, introduced and used to view the mucosa of the colon. And when I heard that an inappropriate practice occurred, the first few things that occurred to me as possibilities might be that one of the internal channels of the GI endoscope was not being properly cleaned and disinfected between uses. So maybe someone had forgotten there was a channel that needed to be reprocessed that could become occluded or clogged with patient debris and therefore needed to be cleaned after each patient procedure. So one possibility is failure to properly disinfect one of the internal channels. Another might be to be reusing tubing that maybe was only supposed to be used on a single patient. Specifically, for example, we're talking about an irrigation tubing. Irrigation would be a feature, a function that the physician would use during the procedure. You get better visualization of the GI tract. You use almost a type of fire hose approach where water is under pressure injected through the endoscope's channel out of the distal tip and against the mucosa or the wall of the GI tract lining. And we're able to clear away debris so that this physician can get good visibility. Is there a polyp there that might need to be removed? And that tubing that facilitates and contributes to this irrigation system is sometimes called single day, sometimes called single use, or sometimes is reused multiple times. And you want to follow the manufacturer's instructions. So what occurred to me possibly was single-use irrigation tubing was being used multiple times and actually used indefinitely, possibly, without ever being discarded, or if it was reusable tubing, without being reprocessed, which we mean by that disinfected and cleaned after each use. So those two possibilities, failure to disinfect the internal channel of an endoscope, improper cleaning and disinfection of tubing used during irrigation. And the third possibility that occurred to me was the water bottle that is used to irrigate the upper or lower GI tract via the endoscope channel, that water bottle might not have been changed. And sometimes you can get retrograde flow where blood from a patient can actually leave the patient's body and flow through this tubing retrogradely into the water bottle that then is used on multiple patients indefinitely. And then all three of these, among many other possibilities, could be exposing patients to bloodborne pathogens to the point of your question.
Right. And I think that was my next question as well. Since these are bloodborne pathogens, how is it that these improper techniques can result in potential exposure to either HIV, hepatitis B, or C?
Well, if those reusable medical devices are being properly cleaned and disinfected, and by properly, I mean according to the manufacturer's instructions, if they're being cleaned and disinfected after each patient use, then they become rendered quote unquote clean and disinfected. Then they have no viral particles on them. And so there's essentially zero risk of that reusable equipment transmitting bloodborne pathogens, hepatitis, HIV from one patient to the other. So inadequate disinfection of something is what's catching my attention over a long period of time as being responsible or possibly contributing to this breach, though not necessarily, because again, we don't know entirely what happened, but they are talking about a solution that was administered down the endoscope channel. And that is why I was focusing a little bit earlier on water used for irrigation, because water is a solution that may not have been what they were referring to. They might have been referring to the solution as a disinfectant that wasn't being properly put down the endoscope's channel, as we talked about earlier, after each use to kill any viruses that are there and therefore prevent patient exposures in future use of the device. I would point out that there are many, many reports in the literature of bacterial infections and outbreaks with morbidity and mortality, in many cases linking it to a contaminated endoscope. So we are focusing on viruses here. We do want to understand what the logic was, and it may very well be sound. We're not including discussions of, for example, multi-drug resistant organisms in this conversation, but it seems that the risk assessment that the Department of Health performed along with the hospital determined the bacteria likely were not posing a risk, that only the viruses were, and they probably think it's a low risk, but it's important to notify patients about this concern anyway and to a commitment of full disclosure.
Right. And thank you for that. And you did mention Vanderbilt's statement telling Fox 17 that they recently discovered an issue in how a solution was administered through the scope during a limited number of endoscopy procedures at the Vanderbilt clinic. I'm not sure if you're allowed to comment on this or not, but as a medical expert, what does this sound like to you? I mean, is this very vague, or I mean, could you even determine what that is just based on that statement?
No, and it is very confusing. A couple points. The first one is we want to know more precisely what happened, because there are GI endoscopy units and departments and clinics all across the country that we want to make sure they aren't practicing the same mistake that apparently happened at Vanderbilt. So if the Department of Health is more open and tells us more specifically what happened, and maybe even more important, what corrective measures were implemented to then stop this problem, that is, stop additional patients from being potentially exposed to these bloodborne pathogens. We want to know what the error was, and we want to know what the corrective action was. And then other hospitals across the country can do diligent audits or inspections of their own GI endoscopy staff's practices to ensure the same mistake isn't being repeated across the United States. It is possible that the same mistake is occurring, that facilities don't even know it. And that's why identifying with greater specificity what exactly happened serves not just to benefit the patients at Vanderbilt, but those all across the country. And so that's really important. Now, to your point of percentage of patients that were infected, I think that you said that a limited number. I think this can kind of catch some people's attention, because limited is a relative term, not a limited number of patients, but let's be a little more specific. Dozens, hundreds, but certainly hope not thousands. But we want to feel that we're getting full information, that we're not necessarily being told everything, but we're only being told that which officials are deciding we need to know. But in my opinion, we certainly need to know more than just a solution being administered down a channel, and that a limited number of patients were affected. And we don't even know over what period of time that limited number was. Was this happening 6 months? Was this happening longer?
Over the last 6 months.
Over the last 6 months. Okay. And then another question is, what procedures are we talking about? Are we talking about diagnostic colonoscopy, where we just kind of go in there and look around? Are we talking about maybe therapeutic
They said
procedures?
endoscopy procedures.
And endoscopy generally means upper GI procedures using a gastroscope. I don't think that's what they meant, but let's, for the sake of argument, say endoscopy is referring to upper and lower GI endoscopic procedures. And I think that needs to be clarified so there's no confusion. that I did see some reports saying that colonoscopy patients had been notified. The question is, did any patients who went through a procedure called EGD, which is a routine upper GI procedure using a gastroscope, for example, to look at the esophagus and make sure it's healthy, were these patients too possibly impacted by this breach? So we want to know more. We're not hearing too much. I think more will become forthcoming, and I'll be able to comment more in detail about what happened. But I think that it needs to be a commitment or an understanding that other facilities may be doing the same thing, and we don't want them to be doing it. So we need to be a little more open and freely exchange the information that we have.
Got it. Okay. And last question. Many, or maybe a small percentage, I'm not exactly sure, but from the people I've spoken to who just hear this story from what I've reported or what they've read, they don't know what a colonoscopy really is or what it entails. Could you go over what that procedure looks like or is supposed to look like for people who are unaware of what that is supposed to be?
So we'll focus briefly on the upper GI procedure I talked about earlier. But to answer your specific question, colonoscopy is a procedure where a fairly long tube, narrow tube, is inserted into your colon and then travels along the ascending, transverse, and then descending colon in order to examine the lining of the colon for polyps, for growths, for strictures, for some types of, sometimes the tissue can become very folded and can collect debris and you can get infections. So the primary focus is diagnostic colonoscopy. For some people at risk of cancer, it's more often, maybe every other year. The average person, you'd have a colonoscopy every 10 years. They are crucial, notwithstanding anything that you're hearing about possible breaches here and there at different facilities. What you simply can do is talk to your physician, ensure that there are no ongoing breaches that the physician is aware of. And when I mean breaches, I mean infection control lapses that might cause some kind of a concern for you, understandably, and it would. And then you undergo this procedure that your endoscopist, it would be a GI physician specializing in colonoscopy. Once every 10 years, you would have a checkup. You do them a couple times in your lifetime, and they would confirm no cancer and take biopsies if there were. And then briefly, the upper GI, which is an EGD, is a procedure that is similar, but instead of going into the lower GI tract, it enters orally through your mouth, down your esophagus, into your stomach. It examines the lining of your stomach, more so, for example, for ulcers, or maybe for some Barrett's syndrome, which is precancerous of the esophageal tissues. So we're looking at upper and lower GI tract. We're looking at precancerous polyps. And this is why we typically undergo diagnostic GI endoscopy procedures. And then therapeutic mean maybe more serious, minimally invasive procedures are being done, but they would only be done as needed, not colonoscopy, for example, every 10 years.
Is that tube that goes up during the colonoscopy, is it the same kind of tube that goes down your throat, or is it two different?
So excellent question. So the colonoscope goes per anally into the colon. What we call the gastroscope goes per orally down the throat and down the esophagus. They are two entirely different instruments, and one is never to be used in the other tract. So, for example, an upper GI endoscope or a gastroscope is to be used only in the upper GI tract, and the colonoscope in the lower. Because the anatomy of the colon is longer than the esophagus and the stomach, you'll notice if you see two GI endoscopes standing side by side, where one tube is several inches longer than the other, you typically know that's the colonoscope, while the gastroscope is the shorter one, because the anatomy of the upper GI tract is shorter, and therefore there's not as much distance it needs to travel to examine all the susceptible tissues.
Got it. Thanks. Thank you. Which one of the procedures, in your opinion, is more susceptible to someone being potentially infected with the bloodborne pathogens, HIV, hepatitis B or C?
So that's a really good question. There's two parts to it. The colonoscope is longer, and therefore there's more surfaces that need to be cleaned. So the colonoscope could potentially be at more risk of a failed disinfection, and therefore a higher risk of an exposure, would be the colonoscope. The upper GI endoscope is shorter, less complex, and therefore is less likely. However, it depends not just on the endoscope, but the type of procedure. The more invasive the procedure, the higher risk you are. So if the upper GI procedure is being done using a gastroscope and it gets a little bloody, because there's ulcerations in the esophagus and there's just a lot going on there where the endoscope is being exposed to blood. That's what really increases the risk. Not so much the endoscope in the upper or lower tract, but the endoscope contacting blood. The endoscope that contacts more blood during the procedure is likely more at risk for maintaining some of that blood, and then if inadequately cleaned, transmitting those viruses from one patient to the other horizontally downstream.
Got it. Well, that's basically it. Anything else that you want to comment on that you're able to regarding the comment from Vanderbilt, the comment from the Davidson County Department of Health? The Tennessee Department of Health still hasn't answered our questions.
So there's two questions. The first question that I had is what caused the patients to finally be notified? It's fair to ask if 6 months have lapsed and you haven't notified patients. Well, if there's no patients testing positive for hepatitis B or C or HIV, you could argue, I don't agree, but one could reasonably argue, no harm, no foul. So the question is, why after the 6 months did the facility finally come forward? And there may be no meat and potatoes to that. There may be nothing to it, but it's a question I would like to know. What prompted ultimately that the patients be notified? I think that's an important question that I would want to have addressed. And
any other question? Yeah.
Now the concern that when we delay this notification, then when we're looking back, the questions then we can lose some trust. Why did you wait 6 months? Why did you not tell us sooner? Interestingly, it is not that common that hospitals like Vanderbilt do go public. So the fact that Vanderbilt went public is important for our education. But then when we're not told as much as we need to know, we're kind of being led to drink water, but then we're not being handed the cup that we need to drink the water from the faucet. So interesting kind of little twists there. But I'd like to know what prompted final notification and what took so long? Did the risk assessment say there was no risk, so we don't need to notify patients? What happened after the 6 month that kind of changed that risk assessment?
Got it. Thank you. And then, just for clarification, so the potential exposure period, I guess, so the window in which these patients at Vanderbilt went for these endoscopy procedures, according to Vanderbilt, was over a 6 month window. Patients we've spoken with range from 3 months to 8 months of being contacted that they were potentially exposed to those bloodborne pathogens. But I mean, is that still a delay to you?
It is, but there are two timelines we're talking about, and I'd like to clarify them just for myself. The first timeline is, when did this breach begin and when was it detected? So depending on how many patients were notified, we'll know whether that was a short period of time. If a few number of patients were notified, dozens, this was a short time between the onset of the lapse and the correction of the lapse. That's one time frame. The other time frame is after the lapse was identified and corrected, how long did it take for the patients to be notified? So those are two entirely different time frames or time periods that we want to know the answer to. So to your question, maybe you could clarify. There are two things going on. If some of the patients we're knowing now, apparently the patients weren't notified until 6 months after the event was discovered and corrected. An important question, when did this event first occur? And then why was it not detected sooner? How often were audits being performed? Would not an audit have detected it sooner? If the breach was only in place for a few weeks or months, totally kosher, we understand it. But if a lapse is going on for years and it's not being detected, that tells me the facility wants to perform its audits more often. Can you clarify for me the time frames you were talking about? Are we talking, for example, what is your understanding of the number of months or days that this breach was in place?
Yeah, and from what we've heard from patients, because Vanderbilt has not responded to us anymore after their initial comments. And then the Tennessee Department of Health has not responded at all at this point. Davidson County Department of Health says they can't give us that information because that's more on the state or Vanderbilt to clarify, from my understanding of the email they responded to me. So the patients I've spoken with say they got the procedure on this date, then 3 months later, they were notified. One patient, another patient said 8 months later after they got the procedure. So it seems to be, and I think another patient I'd have to double check was 2 months after. I think that was my initial story. So it wasn't immediately.
It wasn't. And again, it could be that a good check and balance on this is if the hospital tells us 4% of patients were infected, I don't have an idea if that's dozens, hundreds, or thousands. If it's thousands, that means that lapse was in place for a long time. And that raises quality questions of why it wasn't detected sooner. So we have two different timelines we want to define. One comment you made about the Department of Health saying that they were kind of, I don't want to paraphrase it, but something to the effect of they were deferring and not
Yes,
responding.
Davidson County. Yes, they were deferring, correct.
I would prefer the departments of health not adopt such a policy. The public wants to hear the truth. They don't want to hear someone saying, we can't answer that question. You have to go to someone else. If they don't know the answer to the question, that's entirely appropriate. But if they do know the answer, but don't want to disclose it and then say, well, you have to go to talk to someone else, then we can get into a tennis match where the patient's trying to get an answer to the question and they're not getting it because different parties are passing the patients off to different people. I would like to think that Department of Health, whatever they know, we would welcome them disclosing it. So again, we can figure out what happened, for how long was it happening, and how can we prevent it from happening again, not just at Vanderbilt, but across the United States.